Hello, I'm Charles Wykoff, and it's a privilege and a pleasure to be here with a good friend and colleague in the retina space, Karl Csaky MD, PhD at Retina Foundation of the Southwest in Dallas, Texas. And Karl, you recently presented some fascinating sort of background data on faricimab and the story of VEGF inhibition in combination with manipulation of the Tie2 pathway at angiogenesis in 2021. And I really want to kind of unpack two topics with you. The first related to this improved drying signal that we're seeing in the faricimab DME population, and then more broadly about the possible mechanisms of action for which we're going to see clinical value over time in patients with a broader scope of exudative retinal diseases. Great. So let's start first with the DME discussion, right? So in the top line faricimab DME phase 3 program, Yosemite and Rhine, faricimab compared to aflibercept, we saw consistent signals of improved anatomic outcomes across CST, across the proportions of patients with a quote unquote dry retina, and the proportions of patients with a resolution of intraretinal fluid, improved outcomes with faricimab over aflibercept. And at the most basic level, I think the question people have when they see that, is this all due to a higher anti-VEGF binding capacity of 6 milligram faricimab compared to aflibercept? How do we know that there's a signal in this, that the Ang2 inhibition component is actually doing something?
Right. Well, Charlie, that's a great question. Of course, it's a critical question. And I think the support of the synergistic effect, so to speak, of Ang2 inhibition with anti-VEGF is really, there's multiple ways that support that data. You know, there are times when preclinical observations pan out. Clearly, the preclinical observations that Napoleon Ferrara and other folks did many years ago in regards to VEGF panned out. VEGF clearly is a critical growth factor in many of our retinal vascular diseases. Similarly, if you look at the preclinical data, the totality of the data on the effects of Ang2 and its ability to interact in multiple ways, and they're complex ways, that when you alter the Ang2, Ang1 ratio, and you get VEGF and Ang2 together, it really appears to kind of act in concert. And so now when you have a molecule like faricimab, and you bind both of them together, there's preclinical data to support that that I presented, but there's the pathways themselves are synergistic. So it really makes total sense. And of course, the consistency across the trials, as well as we can't forget that even in the Ruby trials with Regeneron, they demonstrated a similar outcome, and that there was improved resolution of fluid, improved compaction, and this finding, especially now with the Yosemite and Rhine data, of improved intraretinal compaction as well, to me all supports this idea that Ang2 truly is a critical player in these diseases and helps modulate, at least initially, the permeability aspects of the disease. So I think the fact that we're seeing that in both trials consistently across time really speaks to that both of these molecules, clearly VEGF is an important anti-permeability protein, but also that Ang2 is acting in concert. So from my perspective, I think these data truly support all of the wealth of preclinical information we have on the role of Ang2 in retinal vascular disease.
I think you summarized that perfectly, and I beautifully, and I have, you know, if I had to push back a little bit, right, because the counter argument is, all right, Karl, but look at brolucizumab, right, in Hawk and Harrier. We've got a much higher molar anti-VEGF binding capacity with brolucizumab, right, approximately what, tenfold or greater higher anti-VEGF binding capacity than 2 milligram aflibercept in the Hawk and Harrier trials. And indeed, you saw better drying at those pre-specified endpoints in Hawk. We had better, superior driving with p-values associated with them with brolucizumab compared to aflibercept that's 100% due probably to increased VEGF binding capacity. So what really gives you data from Yosemite and Rhine to say there's something more here? And the point from Ruby, I think, is a really good one. But what's sort of your answer to that when people push back?
Yeah,
and
so
say
I think there are several approaches that you have to take. One is you really have to look at the fact that the total amount, the molar equivalents that were given in Yosemite and Rhine of faricimab were really not that large, right? Yes, there was a approximate, when you look at the binding capacity of faricimab, the affinities for VEGF are really not that dissimilar from ranibizumab. And we know that in terms of increasing just the amount of ranibizumab, we don't see really any benefit. So this concept that somehow the molar equivalents of our anti-VEGF agents are what's playing an important role really has not been supported by a wealth of clinical data. And of course, the other aspect is that there is so much excess of our drug in relationship to the amount of VEGF that we're really not, talking about a competitive perspective. When it talks about brolucizumab, I mean, first of all, you're correct. The molar equivalents compared to faricimab are in the order of 8, 9, 10-fold higher. So these are enormous amounts of anti-VEGF. The other thing that I think we have to take into account, and this may have played a role in terms of the brolucizumab data, was the size, right? We've done a lot of work in understanding how molecules get through the retina. We've published work on the transport of compounds through the retina, and clearly, brolucizumab is a very small molecule. These weird FV kind of portions, 23 kilodaltons approximately in size. It's not surprising that they could potentially get into the tissues a little bit better, bind more of the available VEGF, and therefore lead to improvements in drying. But what didn't pan out in brolucizumab compared with faricimab was the durability. So what's interesting is that faricimab in the data that you presented and the data that Jeff presented, it clearly demonstrated that faricimab appeared to have a much longer and better durability, even though on a molar equivalency basis, it was significantly less. So I do think that this idea that it's simply a molar basis of anti-VEGF it's just not supported by the data. I mean, for example, if you want to talk about affinity or binding, if you look at aflibercept, it's an immunoadhesin, which means that it's actually a receptor bound to an Ig molecule. Receptors we know have enormously high affinities. That's why aflibercept has, compared to ranibizumab and even a standard antibody, has a much, much higher affinity. So if you were going to talk and compare purely on an affinity basis, you would have argued that aflibercept should have won the show, and clearly it underperformed compared to faricimab. So I think this idea that it's simply we're arguing about molar equivalence of anti-VEGF is a very small piece. And I think what we're seeing is an additional aspect of biology when we look at the data that you presented and Jeff presented on faricimab.
Carl, fascinating perspectives. Thank you. And the second topic I'd love to pick your brain about is sort of the mechanisms of action of Ang2 inhibition here, right? Because I think mechanistically, VEGF-A is fairly simplistic compared to the Tie2 pathway. I mean, VEGF-A we think of as pro-permeability. We think of it as pro-angiogenesis, neovascularization, and maybe a little bit of inflammation, but mostly the first two. And now you walk through multiple potential mechanisms by which Ang2 inhibition may impact short-term and long-term outcomes for these eyes with various exudative retinal diseases. Of all these mechanisms that you described and have been published on by multiple different authors, what do you think are going to be the most important mechanisms for which we'll see clinical value over time?
Yeah, I mean, I think what we know in terms of this concept of stable versus leaky vessels, we know, I mean, we've had 15 years of anti-VEGF experience, and what we know is we really don't fundamentally disease modify, right? That's why we have to continually re-inject the majority of our patients, regardless of what disease they come into the clinic with. And so one aspect of anti-VEGF is that it clearly affects permeability, but I'm not sure it's addressing the full spectrum of pathologies that are occurring at the vascular level. Ang2, we're hoping, is part of that pathology. And so the idea would be is that if we can get vessels to become more stable, if we can create these tight junctions and the complexity around what's happening when you overexpress Ang2 relation to Ang1 is very complex, but you can simplistically think of this is the vessel is remaining unstable. And while we change the permeability temporarily with anti-VEGF, we're really not disease modifying. And so the hope is that with anti-Ang2, in addition to anti-VEGF, we're reducing the permeability, and ultimately we're going to get to vessel stability. And that's why even in the angiogenesis meeting, I pointed out, and we've talked about this, is that really this is the one time when the phase with the second year data is actually in many ways going to be much more exciting than the year one data, because it's going to be in year two where we really are going to see hopefully this stability potential of anti-Ang2 play out. And of course, in the clinic, we'll see this even more because we'll start to obviously titre our patients off the drug and see what happens. So these are really, a different mindset in thinking about how we're going to approach these diseases. With anti-VEGF, it was all an immediate effect. We got resolution, it came back, we treated, we got resolution. Here, we're not talking about potentially disease modification, resetting the entire vascular network to a stable network. And that may take 12 months, may take 24 months. And that's what the exciting part will be for next year.
Fascinating. So if I had to probe one level deeper on that, so what are we going to be looking at? Are these anatomic OCT-based endpoints? Is this leakage on fluorescein, or is this sort of biomarkers that we don't really understand yet, right? Pericyte survival, fibronectin deposition, all these other sort of secondary issues that we don't have good ways to assess in the clinic. Like, are there certain endpoints that we should be thinking about moving forward?
Well, clearly, the way the trials are set up are just to look at how what you presented, the fact that we really had this large group of patients who went out to 12 to 16 months of interval treatment. The first readout will be, is that maintained, or even the number of patients that are increased in that group increased, will be the first readout of whether we're getting to stability, simply an OCT-based readout, which I think is going to be probably the most valid in terms of vessel stability. Now, ultimately, once we get into the clinic with this drug, there'll be a host of various ways to interrogate, because it's not something that we've ever really thought about. This idea of interrogating vessel stability with fluorescein angiograms or OCTAs in a way that we can somehow measure vessel stability will be the exciting aspect of, I think, the research that's going to come, hopefully, when we have Faricimab in the clinic.
Karl, thank you. Thank you for the insights. Thank you for everything you do in the field. Look forward to more.
Enjoyed it, Charlie. Have a good day.